Welcome to the APSA annual trauma session. I'm Chris Streck, and this is Regan Williams. We're the leaders of the APSA Trauma Committee, and we're very happy to have you all here today. I soon expect it to be standing room only, so we'll direct people to the front as they come. We're going to try to keep the talks around 5 minutes, and then each talk a little bit different from what's happened so far today. It has a discussant already chosen, and then there should be a minute or two for questions from the audience. And we do have a 5 o'clock appointment at the Marina Kitchen Bar for the committee. If anybody is interested in attending, we're going to stay on time. The first speaker is Dr. Peter Yu, and he is going to speak. Can you cue his slide? Is he here? Well,
He's supposed to come to us first, right?
yeah, he's supposed to come here. Well, yeah, it's 4. Peter Yu, are you here? Well, we can circle back to Peter, and I know Cal Gunasinga is here. Oh, Peter, you're here? All right. Without further ado,
It's like a mic drop.
Peter Yu is here, and he is going to speak on African American youths are more frequently subject to lethal force during legal intervention. That's a mouthful. Representing UC Irvine.
Sure. And this will advance my screen?
It will. Blue, green will advance.
Great. Thank you. Sorry. No disclosures. So legal intervention is defined as any injury due to any encounter with any law enforcement official. It's an ICD code, Y35. And we chose to study this because trauma secondary to legal intervention has become an important public health issue. And obviously, we're all aware of recent high-profile events. Previous studies examining this scenario in the pediatric population are few. We were granted access to the National Violent Death Reporting System database. It's a CDC database, and it basically covers all violent deaths, so homicides, suicides, et cetera. And it has several unique data elements, including narrative text written by law enforcement and by medical examiners. We extracted these cases. We divided them into 2 populations, those who are subjected, at least at some point, to non-lethal force, and those subjected to lethal force, and then we compared the 2 groups. As far as how we classified these cases, it was a 4-step process. It was based on ICD codes. It was based on searching the written narrative for key words. We also used a machine learning algorithm called extreme gradient boosting to additionally analyze this text for any words that we might not have thought of. And then once we were able to identify all non-lethal cases, we hand annotated them to make sure there were no false positives. So as far as our results, 1,281 cases of death after legal intervention, ages 12 to 26 years. It was rare to see those deaths in younger children, but as cases became older, we saw more deaths. Most of these deaths occurred in males, and most were due to firearm, 94%, regardless of whether non-lethal force was at some point attempted. African American youths accounted for 45% of deaths in this study, compared to just 22% in the US population for that same age group. Non-lethal force was rarely used, only 8.5% of all cases in this population. We also separated these cases into those categorized as nonviolent and those categorized as violent. And we found that non-lethal force was more frequently used to subdue nonviolent individuals, although still infrequently used overall. Non-lethal force victims were more likely to have a mental health history and were more likely to receive CPR as a life-saving measure. And finally, we found that white and Hispanic individuals were more likely to experience non-lethal force. African American individuals were more likely to experience lethal force. This is despite the fact that African Americans were not more likely to be categorized as violent. We found that white individuals had a 46% increased odds of being in possession of a weapon as compared to African Americans. African Americans were not more likely to be involved in a violent crime. African Americans did have a 59% increased odds of experiencing what we term justified use of force as reported by law enforcement when compared to white individuals. African Americans were also less likely to be intoxicated than the overall population. So in conclusion, most people who died due to legal intervention are exposed to lethal force. Most can be categorized as violent. Nonviolent decedents of legal intervention are often subdued with lethal force. Non-lethal force frequently progress to lethal force in this population. African American youths were more likely to experience lethal force than white and Hispanic youths. They were not more likely to be classified as violent. And there may be opportunities to save lives by more frequently using non-lethal force and adhering to it, and perhaps performing CPR as a life-saving measure. Thank you.
And we're going to invite Dr. Holka up here as our first discussant.
And there are lots of chairs up front if anybody would like to come sit down.
There's some space at the podium if anybody needs a seat up here.
I'm gonna stay next to you.
Oh, please do.
Chris said he wanted us up here. I don't know. Anyway, good evening. So Dr. Vu and his colleagues looked at lethal force and the use of lethal intervention and the interaction that this has in our community and our country. This is not the first time his groups looked at this. They actually looked at the CDC database, looking at just interventions, legal interventions, and just the incidence of injuries. Now they're taking it to the next level, looking at the CDC database and looking at the incidence of lethality. I have a couple of questions, one more specific and then a few more general, kind of 30,000-foot view questions. First is, did you look at a regionality? Was there any differences around the country as to the incidence of this? Secondly, as a practicing pediatric surgeon, what can we do to have an intervention in this at the local level? As a group, as APSA, what can we do? Such as the AMA has a position statement on this. Is there something we can do as an organization? And then lastly, and probably my most important question is, on the icebreaker, you said you thought you were a watermelon, and I'd like you to explain that. Thank you.
Wow, tough questions. So as far as your first question goes, regionalization, that is coming up in our next study. Not only are we going to look at regionalization, but our thought is to look at urbanicity, whether it happens in the city, whether it happens in suburban regions, or whether it happens in rural areas, to see if there's some difference in the frequency with which non-lethal or lethal force is used. And then a part of that will also be region as well. Secondly, what can we do? I've been thinking about that a lot. It's a tough question to answer. I think there are two important things. One, and I think we've all seen this during COVID, we are a very respected profession in the community, and people listen to our voices. I think it's really important for us for this, even though we all have feelings as people, to present the data. I think that is something that we can do and we can do effectively. And the data that our group has seen has painted a pretty clear picture. And if we follow that data as our North Star, I think interventions will become more apparent. The other thing that I would say, so when I was a surgery resident, one of the surgical oncologists taught us for cancer that there's 3 steps: name it, stage it, and treat it. And I think right now we're in the naming stage of this. We're naming it. I think next steps, and we have some thoughts on how to stage it, how to classify it. And once that's done, I think we'll have an idea of where we can intervene. And then I just think watermelon's a great fruit, super sweet, and I like to make watermelon margaritas. So that's it.
We have a time for questions from the audience if anybody has a question.
Lou Malvezzi from Miami. Do you think that you're going to be able to tease out the training of the police groups that are causing this problem? Because I have a bias, and that is if you're in a very big place, they're going to teach you properly. If there's 3, you're going to get scared and something bad's going to happen. But
Yeah, I think that's also a complex answer. So one of the criticisms of the NVDRS database, and it's a great database, is that there's very little information about the law enforcement officers that were involved. We don't know their age, their gender, their race, their ethnicity, et cetera. And several authors who have tapped into this database have called for that to be included. I think that will help. As far as an intervention with our law enforcement colleagues, I think that falls into the staging, the typology. So there's a great paper by Wirtz that came out in 2020 where they literally classified all types of legal intervention homicide. So there were cases where a victim was murdering somebody and then attacked police, right? That's one typology. Then there was somebody who was intoxicated, high on drugs, posing no threat at all. That's a different typology, who also died at the hands of law enforcement. I think that perhaps once we've staged it, that we can start to look for areas to intervene with training for police there.
Thank you.
Thank you.
Comment or question? I couldn't think of it at first, so I was a little slow. Upperman, Vanderbilt. Jennifer Eberhardt, who is a PhD researcher out of Stanford, actually looked at some of the engineering, if you will, and the reactions around law enforcement and imagery. And she studied this in what I'll call the lab setting. And so when we talk about this lethal force, she actually determined that there were some underlying almost neural network biases that were just hammered in. Are you familiar with that work? And maybe you can reflect a little. Yes, no?
I'm not familiar with her work specifically.
So basically, she showed imagery of folks with either cell phones or actual gun models and demonstrated, depending on the amount of melanin content, the reaction time to firing at the image. And unfortunately, if you had a certain level of melanin, you would actually shoot to kill quicker than if you didn't. And so that data is out there, and it's very, very, the precision in which that data was presented leads me to believe that we're really far down the track from just naming. We really need to start firing up some chemotherapy. Could you share with me some of the approaches? Because it's really not a laughing matter. Being the dad of 3 black youths and my senior fellow for life, I mean, as we were both having our children simultaneously, just kind of recognizing the different journey and the path that I'd have to get them to prevent some of these interactions. It was a tough journey, and it continues to be a tough journey. So tell us a little bit about your thoughts about the chemotherapy for this.
Yeah, I think, first of all, Dr. Upperman, I mean, I think most of us, can't imagine the difficulties that your children and you as a father have had to go through. While I'm not familiar with that work, we found similar hints of what that author from Stanford found. For instance, in the previous paper that we wrote, we noted that although there was no difference in height and weight between African American youths and white youths that were harmed by legal intervention, that if you were African American and taller and heavier, you had an increased likelihood of being shot. And that did not hold true for white youths. So I think there is a bias. There is a place where there is racism. I don't have chemotherapy for that. I wish I did. Maybe next year I will. Right now I feel like what I can do is hopefully to intervene on those cases that are a deficit due to training, fear, anxiety, misprocessing by law enforcement. The racism, the bias, that question, that's a bit bigger than me right now. And I'm not saying that to shirk that responsibility, but that's the truth.
Thank you.
Thank you.
Our next speaker is Cal Gunasinghe. She is a general surgery resident at Walter Reed, and she is going to be presenting on pediatric blunt cerebrovascular injury, a retrospective review and further characterization of associated injury patterns and age-associated risk.
Is there a way I can change the presentation? This one's not mine. It's like- Okay, give it a shot, but
It could be tough.
yeah, it could be very tough. The surgery and the mental health movement. Your last name is Gunasinghe.
Gunasinghe. Yeah.
The thing, right? The agenda. Well, in the meantime, I want everyone to look around and see how packed our room is. So if APSA program committee is here, next year we need a bigger room. I did just tweet a picture.
Now that she tweeted it, it actually happened. I think you're good.
All right, good afternoon, everyone. My name is Cal Gunasinghe. I am a resident at Walter Reed, and today I'm going to talk to you about pediatric blunt cerebrovascular injury, or BCVI, and the age-associated outcomes. No, the opinions in this presentation do not represent any agency of the U.S. government. BCVI is overall a rare injury in trauma patients with a prevalence of about 1 to 3%. The biggest outcome or complication from BCVI is stroke. And in multiple series, the stroke rate in pediatric patients with BCVI can be as high as 38%. Within the pediatric population, as you all know, there are various anatomical differences, and this includes the center of gravity for kids, the body surface area, as well as the flexion and extension of their neck, which is most important for BCVI. The purpose of our study was to use age stratification to further characterize the incidence and risk of stroke in patients with BCVI, as well as look at the associated mechanisms and injury patterns in these patients. We did a retrospective cohort analysis of the TQIP database, or the former NTDB, from the years of 2014 to 2018. All patients were 18 years and younger and underwent or suffered a blunt mechanism. We stratified them into ages of 0 to 3 years of age, 4 to 13, and then 14 to 18 years of age. Our primary outcome was the incidence of stroke in BCVI patients. The secondary outcomes were the risk of stroke, as well as the associated mechanisms and injury patterns. We looked at around 635,000 pediatric trauma patients, of which 2/3 of them suffered blunt trauma. 700 of these patients, or 0.15% of them, had a BCVI. If we looked at the blunt trauma patients that had a stroke, about 13% of those patients had a BCVI. And then other injuries that are commonly associated with BCVI, such as basilar skull fractures, cervical spine fractures, and cranial nerve injuries, were also significantly associated with BCVI. The most common mechanism in these patients was being a motor vehicle occupant, and this was consistent amongst all age groups. However, in the youngest age group, 0 to 3 years old, the second most common mechanism was a fall. And it's notable that 10 of these patients, they suffered a fall and had a stroke, but they did not have a diagnosed BCVI. BCVI is then composed of both carotid injuries and/or vertebral artery injuries. And throughout the ages, again, carotid injuries were the most common injury suffered by the patients. Next, we looked at associated injury patterns. And again, throughout all the age ranges, you can see that intracranial injury, which includes something from concussion all the way to intracranial hemorrhage, and skull fracture were the first and second most common injuries seen in these patients. But if you notice, in the youngest age group, the third most common is a superficial injury to a head. So you could be a young patient who suffered a fall, who had a GCS of 14, but then also just had a laceration to your head and also had a concomitant BCVI. The risk of stroke was the highest in our youngest patient group. So when we looked at our youngest patient group, we could say that there was a large amount of patients, or relatively a large amount of patients with strokes without a diagnosed BCVI. So the question we have to ask ourselves is, are we missing injuries? There's only so much we can say with the database that we used, but this is something that to look into more in future studies. When we look at imaging, what's currently used in the adult population is a CTA. Again, with ionizing radiation, it's something that we try to avoid in the pediatric population. However, we did have a high rate of carotid injuries, and ultrasound, we can use that to see if there's any kind of flow dynamic abnormalities that may serve as an additional factor in a screening guideline that we can then push those children to get a CTA or further radiation to be evaluated. And other industries have done this. If we look at the automobile safety industry or the Department of Justice, they actually have done biochemical or biomechanical studies to look at pediatric patients of different ages and to see what actually works best for kids at each age. And finally, when we look at all the current screening criteria that we have, both adult and pediatric, you can see that with a GCS less than 8, this may miss a child, in screening who has a GCS of 13 or 12. With neurological deficits, imaging may already be indicated and the problem has already happened. And then with fractures in our youngest patient population, they may not present with that anyway. So our conclusion is that we need further revisions to our current screening guidelines to include age-specific factors. Thank you, and I'll take questions.
Our discussant is Aaron Jensen, and he's making his way up.
Wow, there's a lot of people. There's seats up front. People, okay. Congratulations on a great study. Really enjoyed the presentation today, and I enjoyed reading your manuscript. Thank you for sending that in advance.
Thank you.
I'd like to commend you on studying what continues to be a vexing problem for us as pediatric trauma surgeons. We just don't know what to do with BCVI still, despite dozens of papers. And I do appreciate you use a large registry to try to solve this problem because it's rare and you need a lot of events.
Exactly.
You have 425,000 patients and only 700 events, which really illustrates how rare this is. But I just wonder, your rate, your calculated rate is only 0.15% in your cohort, and your stroke rate is really small, 3%. Right? Only 24 of the strokes were in BCVI patients. So I have a few questions. First of all, where do you think truth really lies, and how did you control for screening bias in this population? We don't know how many occult injuries there are. We don't know how many missed injuries there are. I suspect there's probably a lot more BCVI patients in this group because we don't screen for pediatric patients. So what do you think really the rate might be, and how might we control for that in this cohort? My second question is about stroke rates. And in your study, you showed that the stroke rate is the highest. You had a relative risk of 200-fold increase in 3-year-olds. Is that just because we wait till they get a stroke and then we CT them, and we don't CT anybody that doesn't have a stroke? Or is it that 3-year-olds have a very high rate of BCVI? Do you think I should be getting a CTA on every 3-year-old with a head injury? I think that's a little bit extreme, but how do I interpret your relative risk of 200 for a 3-year-old? And finally, we know that even when we apply all of these screening tools that we still miss injuries. There's a 2018 paper out of Harborview that says if you use the Utah score that 36% of kids have a BCVI anyway, and they wouldn't have gotten screened. East guidelines, Denver criteria, they all have problems. So how can we use your data to improve upon screening? And how do you think I should be screening these kids? I order a lot of CTAs, probably more than any of my partners, and I still don't ever find a BCVI. And I've seen a patient, and I screen a lot, and I still missed one. They had a stroke, and I hadn't screened them. So how do we adjudicate that?
All right, thank you for your question. So the first question in regards to bias, right? So how did we control for screening bias? And we really didn't, because we are using TQIP or the NTDB, right? So we're using the ICD codes that would indicate a carotid or vertebral injury. And this was one of the things that was really limited in our study. By using these national large databases, we can't necessarily say if the person evaluating the patient fully screened for BCVI, and that's why they have, once they were diagnosed, they had an ICD code. But the other part of that is there's no variable that says that no, there is no BCVI because we screened for it, or it's just unknown because we didn't look for it. I think that's a big limitation. So really, this is just looking at a large population and looking for the incidence of whoever had been screened. For your second question, in looking at stroke rate, I think some of that number, the large number that you see with the relative risk, that comes from, one, having such a small population, right? Because we only have 40 patients, and of that, there was a pretty high stroke rate in the younger population. I think some of it is the small number, but and also if we're not screening or catching the patients in the younger populations, and I think that's where we can really make a change, is in the 0 to 3 age range, and even if you want to extend it from 4 to 6 or 9, because in that range, the most common form of trauma is a fall. And that's what some of the other larger database studies have shown. So I think that's kind of where the stroke rate comes from. So it may not be 200, but it's still a pretty high stroke rate. I think the true number is probably closest, the relative risk is closest for the patients within the 14 to 18 age range. And then finally, what could you do? How can you change this, right? And I think this is the question that we've kind of raised with all of this, is I think we need to start looking at the biomechanical data that is out there from other industries, right? Because the car seats, for example, they've shown that rear-facing car seats are 5 times safer. And if you could notice with the animation there, just the neck flexion and extension from someone in a forward-facing versus a rear-facing car seat is so much more. And using the data that those industries have, and they use for other reasons because they have products, but could be very helpful in how we develop our screening guidelines, or how we can use that for the younger populations in certain age ranges in actually looking at screening. For imaging, I think this is where the CTA kind of comes from the adult population. And contrast enhanced ultrasound I know has been used for other blunt abdominal injuries in the pediatric population. Again, we have no studies that have shown, if we look at patients with BCVI and look at their flow dynamics in their vessels, can we even tell a difference? And I think those are studies that need to be done before actually using other imaging modalities to add to our screening criteria.
I think we have time for one question.
Sorry, Dave Nadrika, Phoenix. So I'll push you a little bit more on Dr. Jensen's observation that your incidence is extremely low. And what I would challenge you is that there's a lot of data in NTDB, and maybe you can impute the data for the screening based on how often they're screening their adult patients. And so we have good fixed numbers for the adult centers. There are a lot of adult centers that do adults and kids, and you might be able to do an imputation of what % are actually getting screened by looking at that data.
Oh, interesting. Thank you.
If I could just tack on to that, there's actually, you won't be able to do this for 2014, 2015 data, but when we switched to ICD-10 in TQIP datasets, there's now a procedure code for CT of the neck with contrast. So, and it's in there, it's one of the named variables in the TQIP dataset. So you could go back, I would hope, and look at your dataset and identify what kids actually had a CT with contrast of their neck.
Perfect.
And you'd have a really nice denominator and a really powerful paper.
Yeah.
So I would encourage you and your team to add that one more step in there, because I think that really will get us a lot more answers.
Yeah, thank you. No, thank you for that.
Thank you. Our next speaker is Dr. Catherine Colbreth. She is a resident in Vermont and currently a research fellow at Boston Children's, and she's speaking on pediatric trauma mortality in India and the United States, a comparison and risk-adjusted analysis.
Thank you so much for this opportunity to present. Not working. Okay, I have no disclosures. Traumatic injury is the leading cause of death in children in the US and in adolescents worldwide. In many low and middle income countries, mortality from pediatric trauma exceeds that of high income countries. So this led us to ask, how does pediatric trauma mortality in India and LMIC compare to the US and HIC? And where are the opportunities for improvement? So the aim of the study was to characterize pediatric injury patterns in India compared to the United States and to assess risk-adjusted outcomes to identify independent predictors of mortality. This is a retrospective cohort study over a 3-year period in pediatric patients that were included in India's Towards Improved Trauma Care Outcomes database and the National Trauma Data Bank. Demographics, injury severity, mechanism, and physiologic parameters at presentation were extracted from the databases, and multivariate regressions were performed to determine the independent predictors of mortality. We also performed 2 subgroup analyses stratifying by injury severity score and GCS. This flowchart shows how we arrived at our final cohort population. We excluded those who were seen at non-university hospitals and those who had isolated extremity injuries, which left us with over 120,000 patients in the United States and over 3,000 patients in India. On univariate analysis, patients in India were younger and were more likely to have fall and burn as their mechanism of injury. They were also more likely to have deranged physiology at presentation with abnormal respiratory rate, hypotension, and abnormal GCS. Patients in India were more likely to have higher injury severity scores, particularly with head and external injuries having, more commonly having abbreviated injury scores greater than 3. Patients in India also had longer hospital stays and ICU length of stays, and over 12 times higher case fatality rate, unadjusted. This graph shows the mechanisms of fatal injuries in the United States on the left and India on the right to help us figure out what these kids are dying from. And interestingly, burns and falls were much more commonly associated with fatal injuries in India than they were in the United States. And also, firearms and other penetrating injuries were not seen as causes of fatality in India at these university hospitals. On multivariate analysis, the most significant predictor was an injury occurring in India with over 22 times higher odds of mortality, closely followed by abnormal GCS. Regarding mechanism, road traffic injuries and falls were actually protective against mortality, and burn and penetrating injuries were associated with increased mortality. Not surprisingly, hypotension and higher injury severity scores were associated with increased mortality. When we did our subgroup analysis, the relative odds of mortality were highest among those who had mild injury severity scores, less than or equal to 8. Similarly, when we stratified by GCS severity, the relative odds of mortality in India compared to the US was highest among those with GCS greater than 13. A major limitation of this study is that injury severity scores can be underestimated in the low resource setting due to lack of or difficulty with access to imaging capabilities and thus potential for missed injuries. That being said, this study does show that pediatric trauma mortality is significantly higher in India than it is in the US, especially on this risk-adjusted analysis. As expected, abnormal physiologic parameters at presentation and higher injury severity scores were also associated with mortality. But interestingly, the relative odds of mortality in India compared to the United States were highest among those with lower injury severity scores and higher GCS scores. While this may seem counterintuitive initially, it does make sense if you think about children with more severe injuries are more likely to die regardless of where they're being treated. But for patients with less severe injuries, it seems to matter more where they're being treated. So this leads us to conclude that low-cost interventions focused on standard timely trauma care could result in substantial improvements in pediatric injury mortality in India. With this, I'd like to thank my co-authors, and I'm happy to answer any questions.
Thank you. And I'd like to invite up Dr. Ryan Spurrier, who is our discussant.
All right, congratulations. That was a great presentation. And I think you may have stumbled upon what philanthropists look for as the holy grail. You know, Bill Gates is always looking for a low-cost, high-impact intervention, and you may be touching on something just like that. I do have 3 sets of questions for you. I know they're hard to remember, so I'll try to make it very clear. The first is with respect to limitations. You already touched on a number of limitations eloquently. There are immeasurable differences, obviously, between the underlying structure of these 2 very different countries, pre-hospital, within the hospital, et cetera. But I think the most glaring one is the differences between the NTDB sampling and TITCO. There are 3 million patients in the denominator, as mentioned in the manuscript, and thank you for sending the manuscript, and only 16,000 patients. And we know India has a much larger population. So what do you think we're missing there? You know, there's probably still a signal. Is it higher or lower, or does it really matter?
Yeah, I think, thank you for the question. I think that a lot of that limitation stems from the difficulty in having a good trauma registry in a country with lower resources. It just takes a lot of resources.
It's hard in this one, too.
Yeah, and so they only have 5 centers that are included in TITCO throughout the entire country of India. So obviously, not as many hospitals are participating, and limiting it to university hospitals also cuts down on the number quite a bit. But we certainly appreciate the ones that are participating. But I think that's the main factor is it's just hard to get buy-in, and maybe they're, you know, they only did it for that 2-year period as well. It was sort of like a 3-year period. It was sort of a 3-year project, so harder to maintain.
Well, you probably have more insight into those differences between the 2 countries than most of us here in this room. If you were to guess, where would be the best bang for your buck if you were to start tomorrow with an intervention?
I think, well, based on these data, I think burns are a really interesting opportunity for intervention, and we want to look further into that particular aspect of this, looking at TBSA and things like that to get a sense of why that is such a high cause of mortality in India. And I suspect it could also be transport times and under resuscitation, or potentially infectious complications down the road for those burn patients. So I feel like that is a potential area for improvement.
Perfect. And then finally, this seems like a great opportunity for collaboration with some of our colleagues. There'll be a Sunday morning breakout session with our global surgery colleagues. And have you thought at all as to leaning on their expertise in dealing with low and middle income countries and these complex issues?
So I haven't had a ton of exposure with global surgery, but I have been on one trip with a pediatric surgeon, and our focus was on education. And I know from that trip there was a lot of interest in trauma training and ATLS training and things like that. So I think that in collaborating, we can really help providers in other countries where they are craving, you know, ATLS courses, and we can really provide that and kind of buff up their trauma program.
Thank you so much.
I think we have time for a question.
Thank you. Juan Gurria from Cincinnati Children's. Wonderful work. Thank you for sharing. I was wondering if you have any data on timing between injury to actual access to care. I'm originally from Mexico City, and I can tell you why kids are dying. It's because they cannot reach the hospital on time. Physiologic derangements are just horrible. The burn physiologist just kills them before they even get to the hospital. Like, transport times are just impossible. Like, you're talking about driving 5 miles in an hour and a half or so without the access to the choppers or the super expedited 911. So I think that's key. I wonder if you have any data on those times at all. It might be hard. But.
Yeah, thank you for the question. I wish we did. I think that's a major limitation of using these databases is they don't capture the pre-hospital course and travel time and pre-hospital care. And I suspect that's why we didn't see any injuries or any mortalities from penetrating trauma and guns and road traffic injuries in the India population, because they're probably not making it to the hospital. So that is a big opportunity for improvement as well, and something that we couldn't really capture with these data, but other studies have shown is a very important area for improvement as well.
Thank you.
Thank you.
Our next talk will be Ella Mahdi. And she is a general surgery resident from University of Rochester, and she's presenting Sustaining the Gains, Reducing Unnecessary Computed Tomography Scans in Pediatric Trauma Patients.
All right, thank you for allowing us to present our work. We have nothing to disclose. Here we go. All right. Trauma is the leading cause of death in children less than 16 years of age. Computed tomography, or CT scanning, has become an invaluable tool in the identification and categorization of traumatic injury, especially due to blunt trauma. As a result, they've increasingly become used as screening exams. We found that children involved in blunt trauma often undergo pan scanning, placing them at increased risk of CT-associated radiation, which therefore places them at increased risk of fatal malignancies later in life. Despite the potential dangers, there remains a high rate of CT utilization in pediatric trauma. There's also wide variability in imaging practices, especially depending on provider type, patient age, and hospital setting. CTs are invaluable for trauma patients. However, we wanted to find a way to filter out patients who have low pretest probability of injury. So we developed imaging algorithms to help us address the high CT rate and variability in practice. The CT HAT algorithm was adopted from the PCARN study. The cervical spine and abdomen pelvis algorithms were adapted from other institutions with modifications based on stakeholders to improve buy-in. We created a novel CT chest algorithm with the premise that a chest CT is needed to assess for aortic and spine injury. We then retrospectively applied these algorithms to trauma activations at our institutions, finding that 52% of CTs done on pediatric blunt trauma patients were unnecessary based on our protocols. We also found that there were no clinically significant missed injuries. For the next part, we aim to not only reduce unnecessary CT scans in pediatric blunt trauma patients, but also to maintain process improvement to continue sustainable changes over time. This was a quality improvement prospective single-center cohort study in which imaging algorithms were implemented during pediatric trauma team activations starting July 2017. Our historical control group included patients seen from January 2016 to June 2017. Chart review was performed to assess for guideline adherence. Guideline adherence was maintained through repeated PDSA cycles, which included interventions such as resident education, in which we provided them with laminated cards of the algorithms for them to keep on them during trauma activations. We also developed web-based and mobile applications to help ease of use. Here's an example of one of our applications to help guideline utilization based on area of injury. We also gave provider feedback to those found not to be adhering to our guidelines. Here's an example of an email sent out to one of our providers. We excluded patients who had penetrating mechanism, suspicion of non-accidental trauma, imaging obtained prior to arrival during the intervention arm, death upon arrival, and those taken directly to the operating room. Here we have a run chart of the mean number of CT scans per patient not indicated by imaging guidelines in each month on the blue solid line, and median in the orange. Across the top, you'll have annotations of the interventions as they're rolled out in consecutive PDSA cycles. The maximum number of scans a patient can receive is 4, 1 for each body segment. We implemented our guidelines starting June of 2017 and did resident and ED team training. In July 2018, a web-based application was launched to facilitate guideline usage. In July 2019, we emphasized the cervical spine algorithm adherence and launched the mobile application. In January 2020, we initiated direct provider feedback to those found to be obtaining screening CTs that were not indicated by guidelines. We then did another cycle of resident education in July 2020. We saw an overall decrease in the number of non-indicated CT scans per patient over the course of the study. And with continued interventions through the PDSA cycles, we also were able to decrease our median non-indicated scans per patient per month even further, as seen by the decreasing orange line. During the control period, 61 patients underwent 171 scans, of which 51% were not indicated. After intervention, 363 patients underwent 531 scans, of which 25% were not indicated. Therefore, we're able to have a 51% decrease in non-indicated scans following intervention. Here we have a breakdown of scans based on body segment. The overall number of CT scans performed per patient decreased from 2.8 to 1.4. The total number of non-indicated scans per patient decreased from 1.4 to 0.3. With breakdown per body area, we appreciated a statistically significant reduction in all groups except for total CT head. The percentage of patients exposed to excess radiation from non-indicated scans decreased from 67% to 27% following intervention. Charges from non-indicated scans decreased by 73%, from about $1,500 per patient to $400 per patient. With this, 146 children were spared excessive radiation, and there were about $218,000 in fewer charges. There were no clinically significant missed injuries identified. Imaging algorithms for traumatically injured patients, coupled with robust QI methodology, can significantly reduce unnecessary CT scanning without compromising care. This practice reduces harmful radiation exposure in a sensitive patient population and can help save healthcare systems money and resources. A mobile application-based tool and direct provider feedback have even further improved guideline adherence. Thank you for your time. Happy to take any questions.
Matt Landman will be our discussant for this paper. Join us.
Yes, this is great. Well, thank you for that talk. It was wonderful. I think the use of a web-based application like yours has incredible benefit for our patients, and I think is aspirational, quite honestly. You know, our literature is replete with studies showing the overuse of CT scans in our patients, whether it's individual systems or multiple systems, like you showed in your manuscript. And I think your pre-post study design and robust quality improvement methodology is laudable. I do have several questions for you related to this. This project started in 2017. Why do you think it's so hard for these concepts to catch on? You know, these imaging studies have been around for years, dare I say decades now, showing overuse. You know, what are some of the reasons do you think that we still have this issue? 25% of the patients that you had in your study after implementation still had, according to your definition, non-indicated studies. Was there a certain characteristic for that patient population that led them to fall out of your guidelines? And then I think from a more 30,000-foot view, a lot of our centers see patients that come from other institutions, critical access hospitals, referring hospitals. How do you get the word out about something like this and create a scenario where these patients are put at lower risk for unnecessary CT scans before they arrive at our institutions? Thank you.
Thank you so much. Those excellent questions. For the first one is to start in 2017, why the long uptake. So when we first started looking into developing these algorithms and implementing them, we went to all our stakeholders, the ED, our residents, to figure out what was the issue and what we found. So when at our hospital, the adult trauma team and residents respond before the pediatric trauma team responds, our adult team's in-house. And when we asked the ED why we were getting such high pan scanning rates, it actually turned out our surgical residents, because of the algorithm used in the adult world where everyone kind of gets a pan scan, we're just extrapolating that onto there. So part of our uptake was educating the residents. On our part, we didn't know that the data was out there, what was a safe screening methodology. So as soon as we got that information out there, I did the appropriate training and included as part of didactics each year. The uptake was very quick. Everyone was happy to have some kind of guideline to help with the ordering the with scans. And it's, as you can see with our run chart, it has stuck really well. For the second question, it was for the 25%. So we do compliance reviews bi-weekly at this point, every 2 weeks, to see where we have a deficit in our compliance rates. And when talking with the ED and residents, we found that there were two areas. The cervical spine, which comes from when a patient has a head injury, has altered GCS. We were getting the CT head, but then when you have motor function normal, and sensation normal. The premise was, let's just scan the neck. It's just right there. It's a few inches more, but that we all know the thyroid is right there. It's a sensitive area. Helping them prevent that radiation exposure goes a long way in preventing malignancies later in life. So that was one area we found that by emphasizing the cervical spine algorithm, we were able to help affect unindicated scans. The second one was the CT chest. When we went to our ED and the residents asking what they were having with the CT, it turned out that there was a line in our algorithm that was kind of up for interpretation that actually made it maybe a bit too sensitive. So by making those modifications, we were able to help with compliance in that area too. And then regarding to the last question regarding the affiliate hospital and referral hospitals, we've started reaching out to them more, similar to the provider feedback letter that we had put up there. We've reached out to them saying, we saw this patient that you sent to us. They had these injuries. These images were obtained based on our protocols. These were not indicated. Here are our protocols. If you have any questions, we're happy to provide you with more information. And our applications are mobile and web-based applications aren't public access yet, but that's the next step. We want to make them available to help our affiliate hospitals use them easier.
Hi, Aaron Jensen, UCSF. Great paper. I didn't notice any indications for CTA of the neck. You don't have to answer that one. My follow-up question, though, is really, one thing that is prevalent in adult trauma centers, and we see in a lot of our transfers, and I'm not sure what your practice is at your center, is what I call the trauma combo 1 scan, which is a non-con head and neck, and then you get the arterial phase of the chest and the neck again, and then the venous abdomen, which rescans the lower. Like, you have multiple scanning of multiple body regions. Have you looked at the adult pan scan in kids, and the kids that actually get a pan scan, you probably can get all the data you need with a single venous phase from the neck all the way to the pelvis. So are you rescanning, and are you trying to cut down on that with your whole body CT rates? Because there are kids that do need a whole body CT, but we can get smart about that too.
So ours, we were just looking at when they hit the ED, what the initial screening scans are. We didn't look at anything past that. At that point, we admitted we've had multiple consulting teams and go based on their recommendations. So we did not look at that aspect of it.
Just a quick one.
Upperman Vanderbilt, lovely control charts. Quick question regarding the app efficacy. Do you have any click data or any data that they actually did use the application?
I do not have that data. That's going to be in our paper looking at utilization of that. Initially, right now, we've been looking at just compliance. Haven't necessarily looked at what way they use to adhere to the guidelines, if it's based off of having the algorithm sheets on them or any other methods. But that's something we can look into for our next step.
Great
Thank you.
suggestion. Thank you.
Thank you.
Our next speaker is Christopher Snyder, and he's speaking on pediatric trauma under triage toward an empiric definition based on risk of requiring pediatric trauma center resources, representing Hopkins.
All right. I'd like to thank APSA and the Trauma Committee for the opportunity to present our work. So under triage and pediatric trauma, at the regional system level, we know that means that a child with major trauma is not treated at a pediatric trauma center. Thank you. But really the concept that we're getting at with under triage is this dangerous mismatch between what the child needs and what the child actually gets. So the implication is the injured child needed the resources of the pediatric trauma center, but was not at a hospital that could optimally provide those resources. So what severity of injury metric should we use to define pediatric under triage? Well, we all know the injury severity score, ISS, very widely used. The definition of major trauma is an ISS greater than 15 per the college. But for a few years now, we've been looking at it from a different way of trying to categorize the burden of injury based on resource utilization. And so we developed a metric that we call the International Classification of Disease Critical Care Severity Score, or ICAS. And this is a novel metric that we've developed and published that quantifies the risk for critical care utilization based on a patient's diagnosis codes. So the aim of this study was to compare the ISS versus the ICAS in their ability to predict the need for pediatric trauma center resources. We used ACS TQIP data for all children age 15 and younger for the year 2019. We compared areas under the receiver operator curve, and we looked at some specific standard threshold cutoffs and compared the sensitivity and specificity of these two metrics. So here's how we define the need for pediatric trauma center resources, and this is based on several papers that have been published over the last few years. So if you needed transfusion of any blood product within the first 4 hours of arrival, if you required any of these urgent invasive procedures listed there within 72 hours of arrival, kind of trying to capture those, delayed failure of non-operative solid organ injury management, the delayed bowel injuries, things like that. And then if you were 5 years old or younger and you required any general anesthesia or mechanical ventilation, if you were admitted straight to the ICU from the ER, or if you stayed in the ICU for 3 days or more, or if you had a child abuse report or investigation. So we ended up analyzing a little less than 100,000 injured children, of whom 16% required pediatric trauma center resources. And among those patients, the median ISS was 10, and the median ICAS was 52. So there's a lot of information on this slide, so I'm going to go through this one. So here we have a comparison of the sensitivity and specificity of these two metrics at these different thresholds. So here we have our ISS of 15, kind of our standard cutoff for major trauma. So when we look at the sensitivity of ISS 15, it's only about 36% sensitive for the need for pediatric trauma center resources. Another way to put that is that 64% of the kids who needed pediatric trauma center resources had an ISS less than 15. So we can say, okay, well, maybe ISS 15 is a little too high, too aggressive. Let's look at an ISS of 5. So even an ISS of 5, the sensitivity is only about 75%, i.e. about 25% of kids who needed these pediatric trauma center resources had an ISS less than 5. When we look at ICAS, we see much better sensitivity at a cutoff of 5, so 95% sensitivity, but you can see that the specificity is not great. Now, specificity would correlate more with an over-triage kind of situation, which we're willing to accept a higher degree of that. And so if you look at an ICAS of 15, then we still have a pretty good sensitivity, about 89%, and our specificity improves to 45%. And when we compare the areas under the curve for these two metrics, the AUC is significantly higher for ICAS. So what can we conclude from this? Well, ISS-based under-triage definitions are really not optimal for injured children. And so I think we should really consider redefining pediatric trauma under-triage based on empiric resource-based cutoffs, not really arbitrary mortality-based thresholds. And if you'll indulge me to get on my soapbox for a moment, I think that pediatric traumatology in general, we really have an urgent need for a gold standard pediatric severity of injury metric. And the ideal characteristics of that, I would think, would be sensitive and specific and appropriately calibrated, simple, so it's understandable, it doesn't require significant burdensome data collection, suitable for children, so not mortality-based. Many of the metrics out there are based on mortality, and we know that mortality in kids is much lower, so we should probably be looking at other outcomes. And then finally, inclusive of all hospitals that take care of injured kids. We know that lots of the pediatric trauma care that happens outside of the pediatric trauma center. It happens at these community hospitals and things like that. So how can we include these hospitals at the system level and not just include the trauma centers that maintain a registry? So thank you very much for your attention late in the afternoon, and I'm happy to answer any questions.
Dr. Notriga is our discussant.
So first of all, thank you for the presentation, and thank you for the timely manuscript. So the authors have looked at ISS, ICISS, and ICASS, and the need for pediatric trauma resources. And what they showed was that the ICAS score had a greater than 95% sensitivity for detecting the need for trauma resources at a threshold of 5. And by comparison, the ISS greater than 15 was only 36% sensitive. And the authors have previously shown that ICAS was superior, in terms of predicting mortality, and they've written some really nice articles on this. So I do think that this metric has some value related to do a lot of things, especially related to quality. But I have some questions for the authors. So one, are you suggesting that we use ICAS to do triage or to assess your triage? And next question is it really fair to judge a center's under or over triage based on injuries that can only be found later? Given you can have the same argument for ISS, okay, so it's not like I'm blaming your score. It's just, maybe we need an assessment that really it can be done proactively. And then the third question is, how do we improve things by using these guidelines? So how do we take this and make field triage or triage better? So do we reverse engineer the criteria? Do we use machine learning to do it? How do we do that? Thank you.
Thank you for those questions. So yes, to answer your first question, this is a back-end metric, just like the ISS is a back-end metric. You're not going to use the ISS as a field triage tool because you don't know what it is until after the fact. But if we look at previous studies of assessing field trauma triage protocols, for example, one of the limitations is we don't really have anything to compare it to know like what's the gold standard that we're holding this up to. So that's how I would envision using this as excuse me, supplementary to other mortality-based metrics. Using that as your back-end gold standard by which you could then develop and test and compare field trauma triage protocols. Excuse me. And then in terms of your question about where do we go from here, how do we apply this? In my opinion, the next step is really trying to understand and define what are the resources of the Pediatric Trauma Center, because that's really what we're trying to get at with the question of triage is matching the right patient to the right center with the right resources. And while there has been work in this area, I think that we lack a consensus definition about these are the things that constitute the resources of the Pediatric Trauma Center. And so we are currently working to put together a working group to do a modified Delphi and putting together a session at Pediatric Trauma Society this fall. So I'll put a plug in for that some of you in this room may be cajoled over the next couple of months to participate in that. But that's I think our next step.
Okay. Hi. How do you use this within the context of a trauma system? And I ask because the sickest kids are the ones that are going to get scooped up and taken to the closest receiving hospital. I live in California where EMS does not intubate kids. They don't carry blood on the rigs. They can't do much other than bag mask ventilation and give some salt water. And if it's an hour, even by air, to a pediatric trauma center and they have a critical TBI, would they not be better served by going to, say, an adult trauma center and getting an ET tube dropped in, getting some blood, maybe some 3%, maybe some Keppra, and flown to the pediatric trauma center with ongoing resuscitation? So I think this is great. I just wonder, how do we take it beyond pediatric trauma centers and use it within trauma systems to make sure, as you said, the kids get the right care when they need it? Because there's a lot that adult trauma centers can do that EMS can't. So how do you see us using this in the future?
Right. No, I think that's a great question. I think that, you know, the purpose of this is not to like try to, you know, put down adult trauma centers or to, you know, call out adult trauma centers or community hospitals that, you know, oh, this kid was under triage because they came to you. Well, as you said, maybe that was the right thing to do, right? No, because they just had to go to the nearest facility. But I think right now we just don't know. Yeah. Because a lot of this care that takes place outside of the pediatric trauma centers that have a registry that contribute to TQIP, we don't know what they're doing. And so, you know, having a metric where everybody that's inclusive, that everyone that takes care of injured kids can kind of be measured in some way, I think is a step towards, you know, really developing a more inclusive and integrated trauma system.
Wouldn't it be great if we had a global identifier that followed the patient through the system? So we could look at, it doesn't sound hard, right? You know, so you could look at the data from the adult center and the ped center and all that stuff. So maybe we can all advocate for that. Thanks.
Thank you.
Thank you.
All right, our final talk will be by Marina Rapucci. She's a general surgery resident at Mount Sinai, New York, but she did this work at Children's Hospital of Colorado, and she's going to be talking to us about factors associated with new mental health diagnoses and resource utilization among pediatric patients following trauma admission.
Trauma remains the leading cause of morbidity and mortality in children greater than 1 year of age. This statistic, however, largely refers to the physical sequelae following their injury. Physical trauma is a well-known risk factor for mental health disorders, and it is estimated that approximately 20% of children will go on to develop a mental health disorder following their traumatic injury. Most prior research on mental health outcomes in pediatric trauma patients has predominantly focused on those with TBI and burn-related injuries. There's largely a paucity of data on the overall mental health outcomes of the pediatric trauma population as a whole. Oh, sorry. Due to this gap in research, as well as the recent national community-level focus on the mental health of children, we sought to determine the prevalence of new mental health concerns following admission to our Level 1 Pediatric Trauma Center, and we sought to secondarily identify risk factors that were associated with post-traumatic mental health diagnoses and/or resource utilization. We performed a retrospective review of children less than 18 years admitted to Children's Hospital Colorado between 2016 and 2019, and abstracted injury and demographic data from our prospectively maintained trauma registrar. We also retrospectively reviewed electronic medical records to identify patients who had a new mental health diagnosis, psychotropic medication prescription, or mental health therapy visit following a hospitalization for their injury. We excluded patients who had pre-existing mental health diagnoses and/or resource utilization, as well as those admitted for non-accidental trauma and self-inflicted injury, to best identify the cohort of patients with new diagnoses or resource needs. There were 3,828 patients admitted to our Level 1 Pediatric Trauma Center in our 5-year study period, of which 9.5% were identified to have a new mental health diagnosis or resource utilization. The most common mental health diagnoses identified were depression and anxiety, and antidepressants were the most commonly prescribed medication. Most mental health resource utilization occurred in the form of mental health therapy visits, with psychologists and social work visits being the most frequent type. In terms of characteristics of patients with new mental health diagnoses and/or resource needs, they tended to be older in age, with a median age of 11 compared to 8 years, as well as be injured by a variety of mechanisms, including motor vehicle collisions, pedestrian-struck injuries, and burn-related injuries. In terms of injury characteristics, those with new mental health diagnoses or resource needs had a greater proportion of traumatic brain injury, intubation, or ICU admission. When we performed our multi-logistic regression model, we identified various factors that were independently associated with new mental health diagnosis or resource needs. Black or other race compared to white race were both associated with an increased odds of 1.8 and 1.6 respectively. Non-sports compared to sports-related injuries were also associated with an increased odds, suggesting that sports-related injuries may have some sort of protective effect against new diagnoses or resource needs. And then we found that head, neck, and spinal injuries were all independently associated with an increased odds. In conclusion, approximately 1 in 10 of our trauma patients developed a new mental health concern or sought resources after admission for their trauma. The most common diagnoses were depression and anxiety, and the most common medication was antidepressants. Most resource utilization occurs in the form of mental health therapy visits. And risk factors that were independently associated with these included increased age, Black or other race, burn, non-sports, or pedestrian struck injury mechanisms, and head, neck, or spine injuries. It's important to note that given the retrospective nature of our study, these numbers are likely an underestimate, as they only represent the data captured by electronic medical record. Furthermore, mental health in children is likely underdiagnosed and underrecognized, and it's important to keep this in mind. That being said, these data are important because we know that most pediatric trauma centers do not provide routine mental health resources to their trauma patients. Based off a recent publication, we know that less than 50% provide routine screening to their patients, and though approximately 2/3 reported providing educational materials for patients to refer to after follow-up, only 6% provide mental health resources within their trauma clinic. Though we all can agree that surgeons are not the best equipped to provide mental health screening or provide resources to these patients, the reality is that until we have better protocols or follow-up in place for these children, members of the trauma team are likely the only healthcare providers these children interact with during their hospitalization. And the responsibility to ensure education and awareness may fall to the trauma team, so that should children require resources, they know where to seek them. I'd like to thank my co-authors, as well as Karen Winery for her assistance with the trauma registrar and the research outcomes and children's surgery group for their statistical support. Thank you, and I will take any questions.
Thank you. I'm the discussant, so we'll make this quick. One, you were the first person to turn your manuscript in, so really great job on that. And I think this is a really important topic and something that's been highlighted recently with the COVID-19 pandemic and our increasing numbers of community violence and what's going on with our poor children right now. So I have a few questions. One, and you touched on this in the manuscript, but not in your presentation. Did you analyze firearm injuries separate from penetrating and blunt injuries, and what effect did firearm injuries have on mental health diagnoses? Number two is, how do you account for patients that didn't seek care? I think those are probably the most vulnerable children, are the ones that never follow up and you never see them again. And then number three, what do you propose as a solution?
So to answer your first question about firearm injuries, we didn't look at them specifically. We did do a separate sub-analysis, which I didn't address here. I did in the manuscript, on non-burn and TBI-related injury patients, and we did find increased odds of penetrating trauma versus blunt trauma for utilization of mental health resources. So though we didn't specifically look at firearm injuries, those would be captured by that. And I suspect that if we looked at that specific subset of patients, we would find increased utilization. However, going into your second point, this data only captures what's available in the electronic medical record. So it actually isn't necessarily a prevalence of mental health diagnoses. It's more of just an acknowledgement of what's in our electronic medical record. And my suspicion is that there's a lot of kids that we're missing. We're going to go back and look at the data and look at risk factors and then try to correlate them with neighborhood level characteristics to see if we are actually capturing in our health system those patients who are at an increased risk based off their injury characteristics. But that's certainly a huge problem and just a huge limitation of doing studies like this in general. And then your last question about proposed solutions, I think it's really important that we better understand what children are at risk for developing these mental health diagnoses and sequelae, as well as provide routine screening for them. There's a lot of literature and a lot of data from psychology, psychiatry that you can provide resources preemptively to prevent any sort of mental health complication. So I think providing some sort of proactive measures would be really important.
Thank you.
Thank you.
Amron, Corpus Christi. Great presentation. Thank you very much. One of the things we know about mental health in kids, it's very related to both physical activity and also nutritional status. And there's a lot of research out there about the incidence of certain deficiencies with neurostatus and trauma with those deficiencies being the tipping point that goes over. we've done a lot of progress in feeding our trauma patients and making sure their nutrition is getting better. Have you guys looked at any additional things that could be done at the hospital level to actually improve the immediate outcomes for the patient and reduce their risk of psychological problems?
Thank you for your question. So no, we haven't done anything on the hospital level. We are now currently screening our patients and we provide them resources in the hospital. But I think certainly next steps would be to better identify what risk factors and what variables we can actually modify in the hospital so that we can ensure that they are, while they're within our care, we're giving them the best chance of not having sequelae. But that's an important thing certainly to look into in the future.
Nice presentation. I'm Barb Gaines from Pittsburgh. You sort of answered this question, I think, in that this was a retrospective evaluation of electronic medical records. So patients were not being screened. There was no universal screening. And so you're really looking, so I think there's that inherent bias that the patients that are being identified are the people that are the patients that people think are more at risk, and that may lead to some of your conclusions. So I think you need to be a little careful about the conclusions. The other thing that I thought was interesting is the large number of TBI, and I'm wondering if you're seeing an overlap between TBI, post-concussive, and TBI-related diagnoses as opposed to mental health diagnoses, because some of the medications are going to be very similar.
So for your first question, yes, this is obviously a limitation, and just in general, studying mental health sequelae in patients would require long-term studies, which would require interviews of patients and a huge resource burden. Most retrospective studies have focused on claims databases. So we were able to use our trauma registrar and we were able to provide some more granularity, but that's certainly a limitation of this. And thank you for pointing that out. As for your second question about the TBI patient, my suspicion, part of why our numbers were so high and why I mentioned previously that we had done the sub-analysis on our manuscript is our TBI clinics at our hospital have a psychologist that's affiliated with them, and it's part of their multidisciplinary team. So those kids already have a linkage to mental health resources compared to our patients who don't have TBI within our trauma system.
Thank you. Just to wrap everything up, there's an invitation to the exhibit hall for poster viewing and wines and snacks. I think when you get to your survey at the end of the APSA meeting, please note that we need more time and a larger room next year. Some suggestions would be, if you like, guideline presentations and how we do it from experts. I think those would, in addition to all this great research, would be strong suggestions for the committee for next year for content. And thanks to everyone for staying over. And for those on the committee, we are recessing to the Marina Kitchen bar area. Thank you.